Hey everybody, welcome to another episode of Union or Bust. You got Organizing Monster here and the one and only Your Union Brother.
How's everyone doing? I'm Chris Lopez, your union brother on TikTok, Instagram, all the platforms. Welcome to a special edition of Union or Bust. We've got Dr. Michelle Cuevas, who is a clinical psychologist, clinical neuropsychologist.
I'm a pediatric neuropsychologist.
And she is a part of the National Union of Healthcare Workers who have been on strike over 8 weeks. Well, anyway, Michelle, tell us a little about yourself.
So I'm part of the National Union of Healthcare Workers, and we have been on strike for over 9 weeks, almost 10 weeks. And so we have been out in the picket line in San Diego almost every day. We also recognize that it's the holiday season, so we took our picket line to rest, and so we're off Tuesday and Wednesday of last week and Tuesday of Wednesday of this week just to give us time to rest. But typically we're out on the picket line Monday to Thursday from 8 a.m. to 2 p.m.
Now, I have 3 daughters, and all 3 of my daughters are majoring in psychology. My oldest daughter's graduated from San Diego State with her BS in psychology. And I have to ask you this question because she wanted me to ask you, so I'm going to get it out of the way right now. She said, what's the process of how you get started in clinical psychology? That's what she wanted to know.
Good question. You know, the biggest thing is just accept and acknowledge debt. That's okay. Debt is
Debt's
okay.
good for you.
That's good, right? And we're a union family, so so debt is all right. But the first thing that you kind of have to do is figure out what type of psychology you want to major in. Like for me, I didn't think I was going to work with kids, but it just kind of fell in my lap, and it was kind of an exciting experience where I started working in houses. I used to do behavioral interventions with kids who have autism spectrum disorder, which kind of sparked my interest in learning about neurodevelopmental disorders. And then you kind of get your master's degree, and then if you really are okay with debt, then you get your doctorate, if you're really okay. And then there's a promised land that happens where you no longer have student loans, and then you're just like, wow, I don't have to eat ramen. I don't have to eat PB&Js anymore. I actually could own a car. It's very exciting. And that's a promised land that you get to.
Very, very cool. Very, very cool.
How long have you been a psychologist?
I have been licensed since 2012. I want to say 2012 is when I got licensed.
13 years.
So about 13 years. Oh, you aged me.
There you go.
Yes.
That's what we do here. We call people out. We ask you what your age is, what your weight is, everything here. Yeah.
I'm a union representative, and I'm always very open with my union members. A lot of them sometimes go through difficult times, and I've battled alcoholism, depression, anxiety. I gave my life to the Lord. I haven't had a drink, going on 15 years. And I think I have an edge, kind of relating to people who are going through things. But we're living in a mental health crisis right now. And I understand you've been on strike, like you said earlier. You said nine weeks?
9 weeks since October 21st.
What are some of the things that you're asking for? What are the issues going on right now?
So I so appreciate you saying that there is a mental health crisis. We are naive to think that there are enough clinicians, psychologists, psychiatric nurses, social workers who are available to treat everybody. There just isn't enough. And so our biggest platform is equity. So we think about if nationally they know that there's a behavioral health crisis, then in Kaiser specifically, you would think that they want to embody what their mission statement is, right? To provide equitable, and equal care to all. But they completely forget about our behavioral health department, our psychiatric department, our addiction medicine department, our medical social workers. They forget young and old who need behavioral health services. So one of our biggest platforms is equity, that if I, as a neuropsychologist in Southern California, work the same job as a neuropsychologist in Northern California, shouldn't we be treated the same? right? Or even amongst within San Diego, right? So Sharp and Scripps and Rady Children's Hospital also hire neuropsychologists, right? And so the mentality is that even within our own corporation, we are not being treated the same. So that's one of our biggest things. The second biggest thing is patient care. So I'm going to dispel a lot of the rumors that are in public media that it's all about money, and that is not the case, right? We acknowledge that Kaiser pays relatively fairly. However, they're not treating us the same. So our patients are waiting 3, 4, 5 months. Our patients who need an assessment from a psychologist are waiting sometimes upwards of 8 months. Like in one county, there might be 2 psychologists in the entire county. Like, how is that possible? Like, we're really well staffed in San Diego, but our neighboring counties are really, really struggling to just find an assessment.
Let me read you a quote. I screenshotted this quote, and I thought it was really interesting. And I'll pull it up as soon as I can here. Here. It says, I'm back to back all day in appointments, said Cassandra Gutierrez Thompson, a licensed social worker at Kaiser, in an October statement from NUHW. I have about 3 minutes to look at my patients' charts. That's not enough. Patients are getting burnt out, therapists who end up leaving because this isn't what therapy is supposed to be. Are you asking for more preparation, more time to prepare for patients? What is it? What does that statement mean to you?
So I appreciate Cassandra a lot. She's actually one of our associates. So she's a master's level clinician who's not licensed, so requires supervision. But generally speaking, that statement means that we don't have prep time, we don't have documentation time, and more importantly, we don't have safety time. So imagine calling our protective services for our adults and children. We might be on hold for an hour. But we can't be on hold for an hour because we have a patient right after that, right? Or let's say that we have a patient who comes in who is in crisis, that they're in, struggling right now, like you mentioned, addiction, depression, anxiety, and they need to see a clinician right away. I have to be able to say, oh, I'm sorry, patient A, you need to hurry up because I need to get to patient B. Right? Well, that's not fair for either of the patients. So we just don't have time. I'll use an example. So in Northern California, they have 7 hours of protected time a week, meaning that they have 7 hours to do what is just humane. Document well, make sure that everything is safe, make sure that the patient is taken care of and heard, right? And making sure that we protect our licenses as mental health providers. Protected. For us, we have 4 hours and it's not even protected. So let's pretend that I have a no-show. I might get patients back to back just because our managers see, oh, great, Michelle has 2 no-shows. Let's put 2 patients in there without a hesitancy. I might even be finishing one patient, refreshing my screen thinking, oh, good, I have time to prep for my next patient, refresh my screen again, and a new patient is in there that I am not familiar with. I have no idea who this patient is.
Wow.
Yeah, it's almost like patients are just another number. Just get to the next one, get to the next one. That's all we're treated as.
Sounds like assembly line psychology.
Yeah, it's really unfortunate. We talk about productivity,
Yeah.
and productivity in so many different contexts means different things.
Right.
And then sadly, productivity here is people, right? How productive can you be? How many people can you see in a day?
Right.
Wow.
I think that goes back to what we always talk about on this podcast is like making healthcare for profit. And maybe that's like an underlying issue here that we don't have to get into. But that's what that is. That's what it is. If a corporation sees us patients as just another number, just to make more money, they're going to try to stuff the nurses or the psychologists or the doctors with as many of us as possible to make as much money as possible for the company. And so I guess would the solution in here be just more staffing then and more protected hours to prepare? Is that what you're saying?
I love this. Yes, absolutely. It's something so simple that seems so simple, at least from my perspective, when I think about labor, right? We're not asking for more money, because if we wanted more money, they would just give us raises and keep on pushing the same or more or double or triple patient care, right? And we'd be like, sure, because you're paying me more. But that's not it, right? We want to share. We want you to hire more. We want to build a robust training program so the next generations of licensed clinicians know how it feels like to do true patient care for all, right? Because we think about what Kaiser's mission looks like, and they accept Medi-Cal and Medicare patients. And so it's lovely to be able to say, I don't care if you have Medi-Cal, and I don't care if you have PPO, and I don't care if you have HMO, we're still going to treat you the same way. That's idealistic. And we want to be able to bring our residents and our associates and our psychology interns in and show them, like, look, you could do good care for all, but that's not what's happening, right? That's the ideal, but what's happening in at least our setting is that that's not happening, where they're like looking for profit. How many people can we put in your schedule? If you work 10 hours, can we put 9.5 patients in your schedule? Maybe, right? And forgetting that people have bodily needs, like they need to use a restroom, right? They need to have food. They need to be able to document, small things.
Yeah, so at the end of the day, the patient suffers.
The patient suffers, the provider suffers. And don't forget that us as providers are also Kaiser members. We're insured by Kaiser, most of us. And so we're looking for behavioral health care. We're looking for other appointments too, and we're also stuck.
And I've been reading a lot of articles, preparing for this podcast. Now, Kaiser's obligated by state law to provide mental health services, even during a strike. And I understand they've been canceling a lot of appointments. Also, what I've also heard is some state officials, state legislators actually coming in and putting some pressure on them to settle this. So, and up to this point, I know we were talking before the podcast, and I said, well, they haven't decided to meet with you, and it's been 8 weeks, and we're in a mental health crisis. I mean, what's going on? And you told me that you have some time set up for negotiating.
Yeah, we have some proposed dates. So I'm lucky to be not only a psychologist, but I'm also on the bargaining committee. I'm also a union steward. So being able to know that they're finally willing to come to the table. Of course, us as a union wish that they wanted to come to the table sooner. Our invitation was open-ended, just like our strike. And they finally come to the table and said, we're willing to propose January 9th and January 16th, but it's to be determined. They haven't identified a location. We, as NUHW stewards, we have said, hey, our offices are readily available for you all. Come on down. Kaiser has yet to accept that, unfortunately, but the hopefulness in this holiday season is that at least we have some dates.
Absolutely. And being a union steward, and do you get paid for being a union steward? This is something that you do for the labor movement? You do to help your fellow union brothers and sisters that are involved in mental health. So, and so you're a neuropsychologist?
I am.
Clinical. Okay, so what are the difference? I went online. I see clinical psychologist. I see social worker. I see social psychology. What's the difference between a clinical psychologist and a neuroclinical psychologist?
It's so funny. There really is a specific difference, and then there's also a lot of overlap. Okay. But the biggest difference, I would say, is the type of assessment that we do. So as a neuropsychologist, I'm not looking for a diagnosis necessarily. I might want to see, like, gosh, let's say, child patient just had chemotherapy, and I just want to see, well, what happened to the chemotherapy? Like, how did it affect your learning and your abilities? I'm not going to say that you have a diagnosis per se, but I might want to see what's happening there. there. And that's kind of the foray of a neuropsychologist, or for an adult, like to look at dementia. Like, we know a neurologist already gave you a diagnosis of dementia, but as a neuropsychologist, we might be able to say, well, how far has the dementia taken you, right? Like, how much memory have you lost? How much ability have you lost? So that's a little bit of a nuance for neuropsychology versus a clinical psychologist. Might also do some assessment, but not to that detail.
Wow, so it's like super zoom in detail for you all. And during COVID, I know that you worked during COVID, and that was a very stressful time for everyone. And I understand, I kind of heard on the picket line that a lot of the psychologists were helping out the people who actually worked in the hospitals. And because, they were risking their lives, going through. Can you tell us, what was your experience during the COVID, the pandemic?
So I have two different experiences, because one is that I work with kids primarily and families, and the second is that we have a training program, an American Psychological Association accredited training program, which is, I just love it so much. And at that moment, we had to protect our trainees as well as us as psychologists and then our fellow members too. So we converted, we pivoted, not panicked. So I'm not taking that phrase as mine. That was definitely somebody else's phrase, but we pivoted and we made all of our assessments virtual. So we had to say, hey, just because there's COVID, we can't say, well, autism disappeared all of a sudden, right? Learning disabilities disappeared all of a sudden. They didn't. And so our kids were struggling. So we had to pivot and treat our patients virtually. So we shifted an assessment that's typically face-to-face over the course of 4 hours in one day to 2 appointments over the course of like 4 hours each, 2 to 4 hours each, all virtual. And we had to meet the families, we met with the patient, we worked with our parents and like, hey, you're going to be our helpers right now. You're going to set up your room this way so that we can do a thorough evaluation of your child. So we really worked within communities to educate like the importance of assessment. We worked within hospital settings, acknowledging that there's patients out there that have more severe medical conditions, and we shifted and we said, hey, how can we meet you at home? And actually, some of those workflows that we developed during COVID times and during stay-at-home orders, we persisted even now because we found out that's more equitable. We're like, yeah, folks in Fallbrook can't make it to one of our Kaiser clinics as readily as someone who's in downtown San Diego. So let's keep on going and let's keep on doing virtual care. It's more, again, it's that premise of like treatment for all.
Yeah. And we can cut this segment out if we don't like it. But does Kaiser outsource any therapy or anything?
Yes, they do.
Okay. Is that you all still, or they just outsource that? Because during COVID, that's when I started a little bit of therapy. And they had me call another company. And then that felt weird within itself to me. And then it was over the phone and this, and I dropped it a long time ago. But so it does outsource some of that work. Is that work supposed to be your guys's?
Yes. Oh, I so appreciate you saying this, because this is what happened, is that Kaiser grew so big but did not increase our workforce. So what did they do? They started doing an external provider network, and they started sending them all out. Well, the problem with that is our patients know us. And they're like, oh, no, I want to go back to Dr. Cuevas. Why are you making me go to so-and-so, right? And then added bonus is that our external provider network, we couldn't have access to their charts, not always. And so then what happened is our patients like, well, I told therapist so-and-so from this external provider network about these things. How come you don't know about this stuff? Sorry, we kind of have to do it again. And so that really was a patient dissatisfied. That's actually one of our main platforms. It's like, hey, increase the workforce internally. Don't keep on farming out our patients to our external provider network, because at the end of the day, they want to come back.
Yeah.
And they're willing to wait.
That's such a corporate greed kind of thing to do, is to outsource. Look at us in America. We outsource manufacturing. We outsource everything. That kind of goes back. Does the outsourcing cost them more money by any chance? Do you know that?
I don't, but I would be thoughtful to think for one employee of Kaiser, right, they provide benefits. They potentially provide some of our retirement benefits, which are different between some providers. And they provide medical care, rent, electronics, right? Like all of the platforms that we need to use internally. They don't have to do any of that for our EPN, right? Those people are private. So the assumption is that they're paying them for services rendered, but probably not as much as they're paying for us.
Gotcha. The only reason I bring that up is because one of the companies we're currently negotiating with, it's called Encore, and they're the AV providers in the hotel. So they set up the lights, the cameras, everything here. They sell this kind of stuff up in ballrooms. And one of our arguments is you shouldn't outsource or subcontract to all these other companies because it costs you even more to go to them. For example, they would pay like $500 day rates for these AV technicians, or they can just pay their staff a little bit more to have a better retention rate, to have a better, healthier workforce, and they're your employees. But they don't care about that argument at all. They just care about moving numbers, paying their employees as little as possible with as little benefits as possible, but it doesn't sound like it's the same thing. So.
Well, it is a little bit. So in that, more bang for your buck, right? So, hey, I could outsource all these folks, and maybe today it costs us less, but in the long run, it costs us more because they're not recognizing that there's no reciprocity to these external provider networks. So guess what? These are patients who might be in crisis, who are coming back to Kaiser, who need to have more support, or who need to have on-duty crisis intervention. And these other EPNs can't do it, so they're coming on back. So they're actually costing Kaiser more on the long run, not realizing, wait a minute, if we just kept them in-house, we would know if they're in crisis. We could provide them with support right away. And you get a happy clinician saying, I get continuity of care. I get to treat my patient. I recognize that there's some triggers that are happening with my patient. It's not like a new patient to me. And so I could be preventative. But if I keep on sending them out to EPNs, the EPN doesn't know them.
Kind of like if you go cheap, it ends up being more expensive.
Exactly. Yeah. Right.
Going cheap gets expensive.
Yeah.
I remember you saying that. I hadn't heard that term until you told me it.
My mom says it, but she says it in Spanish.
Oh, I love that.
Yeah. So as NUHW gone on strike, you all have gone on strike before this? Is this the first time that you've
No, we've gone on strike before, but they've always been time specific. For Southern California, this is the first time that we've had an open-ended strike.
Gotcha.
Yeah.
I want to circle back to the mental health crisis. So much is going on in the world. I know we could talk about a lot of different things, but if somebody doesn't have health care and they need help, what can they do? Is there a number they can call or anything like that? Or is it just, it's even people with health care though, I understand it's difficult for them to get an appointment. So where are we?
So there's actually resources. It's really quite wonderful to live in California because there is so many resources. The only unfortunate thing is that it's hidden, right? So unless you are really intimately aware of the system, sometimes it's hard for you to find those resources. But those resources are out there. Specific to Kaiser, I would say we have walk-in clinic. We have a Believe Me policy. We have pay-as-you-go, right? So that's one kind of consideration. But generally speaking, there is 211. So you absolutely can call 211, and it's almost like, gosh, I'm going to date myself. The yellow pages of behavioral health. Oh, yellow pages. Okay, because I remember my parents talking about yellow pages, right? Like, let me not be dating myself, but it's like the yellow pages. It's like your 411 on behavioral health resources in your community. So you could call that. You hit a live person and you say, hey, I need X, Y, and Z, and they might tell you, okay, if you're insured, this is the number that you call. If you're uninsured, these are some resources that are available to you. And I think that that's kind of a wonderful gift. If you're a child, you have behavioral resources in your school. So if parents are really looking for resources and they're just not sure, go to your school. Your school has those resources, and it's provided by the state of California.
I think people who are in need of mental health care, sometimes they're not in a position to think clearly. There's could be battling anxiety or depression, whatever it is, And it's difficult for them because I even think as a layperson, I think of the healthcare system, it's huge. The mental health system is like, where do I go? And it's kind of its own like overwhelming situation, not to mention the anxiety maybe of how much is this going to cost me? Is it better that I just stay home? So it's...
Or Joe Sixpack.
Yeah.
Have you heard of that?
No.
Sociology term. I'm a sociology major. Or so are you, no?
No, I'm criminal justice administration.
Oh, that's right. You should have been a cop.
Yeah.
Nice.
I actually wanted to go into the Secret Service.
Oh, damn. What the fuck?
Well, that was when I was 18, 19. So.
Oh, wow. I didn't know.
You've got the interrogation down pat. Oh my gosh.
Well, I tried to be a cop, but they didn't let me. But no, I was going to ask, what did I just ask?
You were talking about Joe Sixpack.
Joe Sixpack. So Joe Sixpack, we learned in sociology that it's like Joe comes home from work. He's tired. He's working 40 plus hours a week. And in order to cope with society and alienation and living paycheck to paycheck, he has to get a six-pack every day and go home and just drown his sorrows away, numb himself away. And that's our mental health. That's the thing that we learn in sociology. Yeah. That's our mental health right there. It's just go home, suck it up, drink a beer, and start over the next day. So there, for the ones that don't know, just drink a six-pack and you'll be fine.
I do not endorse this.
I'm just saying, but we learned it in sociology and at SDSU. So it's such a common theme in our society that there is no mental health for us. Like we shouldn't be encouraging more of it, more funding of it, more taking care of our therapists, social workers, clinicians, because our people need it now more than ever. So instead of drinking, we should stop.
Well, I appreciate you saying that because especially when I think about like ChatGPT and other AI resources, like society is like, no, you don't need behavioral health care. You can do it on your own. And I think that is such a misunderstanding. If I had a heart attack, I'm not like, I got this. I'm going to Google search how to do this and I'll be fine, right? Like I could totally intubate myself. No, we would never say that. We would say, no, we have to go to the doctor. We have to go find, experts in the field to provide us with medical wellness, right? Healthiness. And what we fail to look at is mental health is not negative. We are being mentally healthy and there's mental illness. And I want to destigmatize that. Like we have cardiac illness, we have mental illness. And so when we think about it that way, it's like, so could I do healthy habits to increase my mental well-being, my mental health? Yes, absolutely. But when push comes to shove, why am I forced to bury it down? Why am I forced to self-medicate when I actually need an expert to help me through this? And I always think about this when I talk to my patients. It's like, we are your employee. We have no idea what is happening with you until you tell us. And once you tell us, then I could help you and I could support you and I could guide you and I could be that expert. It's just like if you go to your cardiologist and your cardiologist says, hey, your cholesterol is pretty high. You probably shouldn't be eating that many fatty foods like chicharron and you shouldn't be eating lechon. Like I'm Filipino, so like cutting out pork is really hard for me. I'm like, oh my God, like what is this? But like, they would say that. Here are my recommendations. Here's my prescription. But you as a human being have a choice.
Right.
And you take it home.
And that goes hand in hand with the whole WebMD thing, right?
Yes.
Like we think there's something wrong with us and we start going on WebMD or whatever the website is.
Yeah.
And all of a sudden we diagnose ourselves with cancer.
Yes.
Like, oh my God, I'm going to die. So yeah, maybe that doesn't work that well for us, like because we're going to think the worst anyways. We always need a professional to be able to diagnose us because you know what you're looking for.
Right.
We don't know what we're looking for. We think we know it, but we don't know.
Yeah.
My wife, sometimes she'll start looking through the whatever, something's wrong. Oh, I just found. I go, look, honey, you just don't know what you don't know. You really need to go just get an appointment. Don't give yourself an anxiety attack going over all this stuff, thinking you have something and really you don't.
Yeah, when I took a psychology class at City College, I think it's psychology. I don't know what it was, but it was to study the WebMD, the DSM-4, and then it was about psychological issues and this and that. By the end of that class, I was diagnosing everybody. I'm like, oh, you have depression, you have PTSD, you have split personality disorder. I was diagnosing everybody, but that's it. Like we don't know everything. We don't go through all the trainings and classes and schooling and going to that much debt to actually know what we're talking about.
Well, even like I would say, like there's a like you ever have like that special aunt or uncle who knows everything, like oh, I know like Tita Shine, she's gonna say something like if I tell her I'm depressed, she's gonna tell me how I'm gonna feel, and she's gonna tell me the whole like prescription of that, has no expertise, right? And that's kind of like diagnosing yourself, right? Like you think that, well, just because you have this lived experience, you must know. But that's not the case, right? So you might go to your trusted aunt or uncle and they're like, oh, they have words of wisdom and it's wonderful and whatnot. But that's not the same as going to a professional. And like I use my own like lived experiences. Like so my daughter was looking at a dog. We were at a restaurant and she was very little and she hit her head on the concrete. And I immediately thought the worst thing. I was like, oh my God, she's concussed. She has a head injury. Like, and this is my field. This is my field of expertise. And so I take her to the emergency room and I was like, I know it. I know you guys got to do an MRI. You guys got to fix her. Something's wrong with her. And the emergency doctor is like, Michelle, are you serious? Like, she's talking, she's walking, she's not crying, she's not vomiting. Just watch her. And I was like, yeah, that's true. Like, you need to kind of alleviate those panic, right? Like, it's like, even though you might think you know, even though you went on Google Scholar and you looked at Google and you looked at WebMD and you're like, I heard all these symptoms. Like, someone needs to be like, all right, Juan, just calm your horses. It's all right. Go to the expert and see if that kind of meets your belief systems, or maybe it's different, you know? But I think it's like important for us to do wellness and well-being checks, but also to say, hey, it's time for me to go to somebody who knows a little bit more than I do.
Yeah.
I never took a psychology class until I went to college, and I took abnormal psychology.
Oh, no.
Oh, my gosh. It was, and I remember Dr. Bird. I don't know where she is now, but it was very interesting because it was the DSM-4, but now it's the DSM-5, right?
5TR, yeah.
5. Okay, so that's probably what my daughters are studying in psychology. But it's interesting that, you know, I think you're kind of right. We say, oh, that person, oh, he's an alcoholic, or that person, you know, and we just throw stuff out. But the DSM-5-TR, you said, there's specific guidelines. You know, you have to, you know, go through in order to get a diagnosis. Now, when I went to college and took abnormal psychology, they said depression was like the common cold of psychological disorders. Is that still the case? Is that kind of like the most common, or is it?
I think it's the most identifiable, right? So like when you think about depression, anxiety, those are most common ones that you hear all over the place. And I have to acknowledge, like I have a pet peeve. Like sometimes I'll go to Target and then I'll hear like a mom saying, oh, you're so OCD right now. Or, oh, your ADHD is like whatever. Or, oh, you're so whatever. And they'll throw out these diagnoses. I would never say, oh, you're kind of a little cancery right now, right? I would never say that. Or I would never say, oh, you're kind of like a miscreant. You're a little bit of a psychopath. So we kind of throw these phrases out without realizing there's actual gravity with some of the diagnoses. So that's kind of my little pet peeve. But to your point, yes, anxiety and depression are really common. But if you are aware, there's a whole chapter on depression. There's a whole chapter on anxiety. And there's so many different types of depression, so many different types of anxiety. But those are the ones that I think are more digestible to you know, lay people. That like, oh, I have depression. Yes, you do. But what type of depression? And what does that look like to you?
Interesting.
One thing that I did learn was that what is it called? When you're depressed, bipolar.
Oh, yes.
Bipolar is not like one day you're this and one day and the next day no, it's like more seasonal.
Yeah.
That's one thing that I remember still from that class.
Very nice.
Yeah, so I think that's important to understand because a lot of people are like, I'm bipolar. Today I'm this, tomorrow I'm that. But because I think these are just very catchy things to say, and there may be like quick outs. You know, like it's a quick way for us to justify in our head why we just did what we did.
Yeah.
You know what I mean? So, oh yeah, because you're bipolar. That's why you just did that.
And in some ways, I like embrace it. Like there's a new movement like about neurodivergence, right? And where, I've been hearing more young adults talking about I'm more neurodiverse. I may have autism spectrum disorder. I might have a learning disability. I might have ADHD, attention deficit hyperactivity disorder, but I'm diverse in that way. And I love hearing those phrases because you're normalizing something that years and years ago, I think about even my own parents' generation. Oh no, we don't talk about mental illness. Oh no, no, no. Theo so and so is like that. He's just weird. Like he's just gonna go in the corner somewhere and not ever identify who he like truly the illness that is within him. And so I love hearing those phrases because it is catchy. I just want it to be more of like, can you say those words and have an acceptance of behavioral health? And then also acknowledge like these are real diagnoses that someone who truly has that diagnosis might feel really like hurt. Like, wait, you don't understand my lived experience of having bipolar 1 or bipolar 2, or having depression and having this deep, deep feeling of depression, right? Oh, I'm just depressed today. Well, I feel depression all the time, and I manage those symptoms, you know?
Yeah.
So, one of the things I do remember from abnormal psychology, they talked a lot about, well, maybe they didn't talk. I loved Abraham Maslow. And he talked about, different behavioral models for psychology, and they talked about food, drink, shelter, safety needs, and all the way up to self-actualization. They said, maybe Eleanor Roosevelt or Mother Teresa were at that level, or but what I thought was interesting is that I think I wrote a paper that if people don't have their basic needs taken care of, like people living paycheck to paycheck, people can't pay their rent, pay their bills, that could be a factor in psychological disorders. So right now, 60% of maybe I'm going into social psychology. I don't know. You can let me know. But 60% of people are living paycheck to paycheck. People having trouble paying their rent, paying their bills. I think when I think about the mental health crisis, and I don't want to I'm not diagnosing, but what do you think is one of the contributors to this mental health crisis in the United States?
Oh, that is such a hard question. Just because we think about which came first, right? The chicken or the egg? And when we provide basic needs for everybody, would there be an elimination of mental illness? And that's not necessarily the case, right? But I will say that it contributes, right? We are intersectional beings. Have you guys ever heard of intersectionality?
No.
Oh, so intersectionality is like, for instance, I'm a Filipina female. Another Filipina female is not the same person, right? They might have different lived experiences. Their socioeconomic status might be different. Their level of education might be different. Their partnerships might be different. Their sexual orientation might be different. And their religiosity or spirituality might be different. And all of those kind of factors are contributing to who we are, right? So when we think about somebody who might be going paycheck to paycheck, one person might be like, well, you know what? I could be resilient and I could find other means of survival. And another person might be like, gosh, I'm living paycheck to paycheck and I can't even get my basic needs met. What am I going to do with myself? Right? And so those are two different people having a shared lived experience of living paycheck to paycheck. So I'm not going to answer your question because it's just like there's just so many different factors that are going on right now. But truth be told, it's really providing that toolkit to all, being like, so person A who's living paycheck to paycheck and really feeling paralyzed right now, here's some supports and here's some resources, and let me reach out to you and provide you something to get you off your feet. And person B who's living paycheck to paycheck but is feeling a little bit more resilient, here's some tools to get you more resilient and encourage that resiliency, because I think that having a script for one person is not always going to be the same script for the other person.
Speaking of resiliency, I want to go back to the strike real quick. So you all have been on strike for 9 weeks, and you all are still out there in the picket line and still fighting. How's the
So it's so funny. I was just talking to one of my fellow coworkers on the strike line last week, and we were saying, God, this feels so bittersweet, because when we were working, we never saw each other. We were so busy that our doors were closed. We didn't know who was in the clinic or not, who was working remotely. We just were basically getting our basic work needs met, right? Like, hey, I have this patient in crisis. Can I just send them to you? Or I don't know what to do with this patient. Can you send us this? Or I have to follow this workflow. Can you help me out, right? On the strike line, we truly became brothers and sisters. I know about their kids. I know about their families. I know about their resources. I know about their interests and hobbies and things like that. And this is, if nothing else, this is a testament to union strength, that when we have a shared cause, we become closer and more cohesive and loving to each other, because we're looking at them as, hey, you're my family now. You're on the strike line with me. You also have the same interests in mind of equity, of support, of good patient care, of values and things like that, that we have similarities. And so with that being said, we're kind of bittersweet. Like, we want the strike to end. We truly do. But we're also like, are we going to lose this kind of relationship? I hope not. So going back to Maslow's, hierarchy of needs, it's like, we need a paycheck. We need an income. We need benefits. We need to make sure our patients are protected. That's kind of our added hierarchy of needs as clinicians. But we also need togetherness, and we need unity, and we need to come together and have those relationships still. So the spirit of the strike line is very strong. And I would say across Southern California, even though I might be hundreds of miles away from like LA County, my brothers and sisters in LA County are still talking to me. We're still texting. Like, when you mentioned Cassandra, I was like, of course it's Cassandra. She's like a fireball of like liberation movement, right? And I care about them. So we're really strong. We're hoping that the strike ends, but we really truly believe that having this open-ended strike really opened our eyes up to the disparate practices that Kaiser is doing, right? They try to tout that we are healthcare for all, but only for some, right? And we're seeing this.
Right. That kind of reminded me of a story with Encore, the same bargaining unit that I organized a couple years ago. When we were doing like solidarity videos, I was interviewing different workers that were part of the whole organizing campaign. When we were done interviewing him, he said like, hey man, before this I felt alone. I felt I was the only one that felt this way, because they're in like 24 different properties. So if you're in this property, you're in this property, and you don't really see the other coworkers. So he's like, but with this fight, with this organizing campaign, it brought us all together. I don't know what's going to happen. I don't know what the contract's going to look like, but it already created a family and a bond between us that we didn't have before. So I think this organizing drive for that. So it kind of goes back to what you're saying on the picket line. Now you're really becoming brothers and sisters in arms almost, fighting for the same thing, the same cause. And another question about the picket line, about the strike, how's the community responding? And like, are people driving by and honking, or are they driving by and telling you like, get back to work,
So we just had a press conference with some of our patient members just last week. And generally speaking, I'd say our patients are with us, and it's bittersweet again, because we want our patients to get their care. We don't want them to wait for us, because we were like, gosh, you need your needs met. But there's a lot of solidarity with that too. So we have over 500 patients across Southern California who have reached out to NUHW via various means and have said, hey, we're struggling right now, but we're in it with you guys. So if you guys are willing to stay out, we're going to be out too. So we have a lot of support. I do appreciate that, we'll have organizations that are also supported by Kaiser, that shall remain nameless, honk and like support us, come out to the
Nice.
picket line, right? Some of our employees that are also labor represented that also work for Kaiser who are not on strike currently have come out to the picket line during their lunch hours, during after hours, just to say, hey, we're here with you. We've gotten huge community organization support from labor leaders, from elected officials. So I think that even though there might be small few naysayers, generally speaking, we have a lot of love in our community.
Is there a way? People could donate for like a hardship fund for?
Yes.
So tell us about how can people like donate to help out NUHW?
So I certainly want to make sure that there's two websites that I want to go out there. One is kaiserdon'tdeny.org, and that has our patient messages, our stories about our patients, our members, things like that. That's really heartbreaking, and it allows you to know that services have been denied despite all the other public media and press releases that Kaiser has put out there. The second one is NUHW.org, and NUHW is our National Union of Healthcare Workers, and on there they have our strike fund, our hardship fund that we love donations. We really appreciate it. We're trying to make sure that all of our members who cannot find work are able to get supported, particularly during this holiday season. And my little plug is that those who are associates, who are unlicensed, they're probably the hardest hit, as well as our registered nurses, our psychiatric registered nurses. We're licensed. So can we go to Octave? Can we go to all these external provider networks and find like contract work? Sure. But those who need supervision and support, our psychiatric RNs, they have to go through registry. They may not find jobs, right? So I'm always thoughtful of those individuals that need the most support during this season.
It's about solidarity, and the stories that you were saying about being on the picket line. I remember being on strike also, and I remember this guy Joe Yankee, and when we were inside the stores, because I used to work for Vaughn's, we just did not get along at all, and we were always, it just seems like we were always fighting. But I tell you, we were on the picket line. We were out there about 4.5 months, and he'll call me up and I'll call him up, and it just, solidarity kept us together. We disagreed on a lot of social issues, but when it came down to kitchen table economics, when it came down to healthcare, because we were out on strike, fighting to have affordable healthcare. So it was just really good to have you on this podcast, and I don't know, what else do you think?
No, yeah, definitely. I really appreciate you coming on. We've had like nurses in November. We had a few nurses come on, a few episodes about that. And we're big advocates for like Medicare for all, single payer, because we believe that everybody should have health care, whether it's mental health or just medical health care. I think that's what holds us back as labor, and we can cut this out if it's too controversial, but we believe that we should have like single payer here in the U.S. Like every industrialized country has some form of single payer, because they believe that having a healthy society is important for the productivity of the country, of the people. We should be taking care of our people here in the U.S. So on this podcast, we make it a theme. Like, we need to keep punching up and keep fighting for a single payer in California, but in the U.S., we can't support like candidates because we're taking like C3 money.
Sure.
So we can't endorse anything in particular anymore. We sold out to the devil. Yeah. It's whatever.
We're part of the system.
We're part of the system now, and that's what they want to see. Like, now we're like dependent on that grant money. Yeah. So sign on to our Patreon so we're not dependent on that money. Anyway, so yeah, like, thank you for coming on. Any last words that you have for our viewership? Maybe like when's your next picket line and where you're gonna be and how do we support?
So definitely we'll be there on Monday. So we're at our San Diego Medical Center off between Ruffin Road and Claremont Mesa. That's the newest hospital for Kaiser Permanente. So we'll be there from 8 a.m. to 2 p.m. on Monday. We will be back on Thursday next week. So please come and support. We have our community sign up. If you're a patient of Kaiser and you know exactly what I'm talking about, come on down, support us. We also have a patient sign-in sheet. If you guys are interested in donating, definitely check out NUHW.org. And so you're able to look at our hardship fund as well as the stories and updates along our whole kind of strike story. And then check out KaiserDon'tDeny.org. And I definitely think that those stories are really heartbreaking sometimes, but also enlightening, and really knowing what our struggle is.
Cool. Well, there you go. All right, everybody. That was another episode of Union or Bust. Make sure you follow us, like us, subscribe to us, subscribe to our patreon.com/UnionOrBust podcast for $5 a month. $5. This Coke is probably $5 now if you go to the liquor store. Right, so there you go. So yeah, please support us. Support the Kaiser workers out there on strike. And just solidarity.
And I'll put all the links in our bio, okay?
And there you go.
Thanks.
Thank you.
Cool. I'm going to go check this out real quick. And